one of the biggest things now is accountability. Historically, in this industry, there's been very little accountability for how programs provide treatment, whether the practices were in fact best practices or research evidence-based practices or just anecdotal things that people thought would help somebody get better. Counselors, credibility, who is this person that's doing the counseling, what is their training, what is their educational background, is there any kind of baseline standard of education or expertise that they bring to the table. All of this is relatively new. It really kind of started with managed care in 1990 when it came out that payers, primarily insurance companies, wanted to know why you are doing what you're doing as a program. And secondly, who are the people that are doing it? And programs had to start explaining why they were putting people in certain levels of care, outpatient versus inpatient, length of stay, 28-day programs, 60-day programs, year-long programs. Why are you choosing to put this program in this person in this level of care for this length of time? And who are the people that are providing the services and what are their qualifications? That's a big change because we're having to explain what we do, and it forced a lot of programs to develop clinical justification for their systems. Another big change over the last 10 years is the integration or combination of mental health and substance abuse. We are seeing now, thank God, that many of our clients, depending on what research you look at, anywhere from 40 to 60% of all chemically dependent clients have a coexisting mental health diagnosis. And almost vice versa. Many people with somewhere between 40 to 60% of people with mental health diagnosis have a history of substance abuse. And so we're seeing more integration. We're seeing more interdisciplinary treatment teams. We're seeing treatment teams that have representation from mental health and substance abuse. The mental health industry is embracing and becoming much more educated about substance dependence, substance abuse, and the substance abuse community is becoming much more aware of mental health and how to treat those types of diagnoses. We're also seeing in the last 10 years more awareness around cross-addiction and being addicted to prescription medications, or not just treating the drug of choice. So if a person comes in for cocaine, we're also recognizing the danger of alcohol. There used to be times when people would go to treatment, and if you went into treatment for cocaine or heroin, in some programs, if you did well, you could actually get your drinking privileges back, or they would celebrate graduation with champagne. That's unheard of now. You would never see anything like that happen these days. And then lastly, we're seeing a lot more professionals get training on addiction treatment. Marriage and family therapists, social workers, physicians. We now have the American Society of Addiction Medicine, so physicians are able to get trained in addiction studies, because historically, marriage and family therapists, social workers, physicians, psychiatrists, in all their education rarely got more than 3 weeks worth of addiction studies unless they sought it out as a specialty. So we're seeing a lot more people recognize the gap in terms of expertise working with this population, which is probably the number 2 or number 3 public health problem in this country, is addiction. And it's a shame that more providers or treating professionals don't have the education. So people are recognizing that and starting to do something. And if I were to add one more thing, I would say that addiction treatment has less of a stigma in the last 10 years than it did years ago. Addiction treatment is almost trendy. We're seeing the movie stars and the celebrities are seeking treatment, and it's not such a shameful thing.
that it needs to not be just a, a philosophical or theoretical idea that that many people have been talking about for a long time, that, how to move that into reality, that really requires some infrastructure, things that we didn't know that we would need in the beginning. I think the greatest challenge has been funding, federal funding specifically. I believe it's probably about 40 years ago that they separated mental health and substance abuse funding, thinking that that was a good thing to do. When you're trying to have an integrated model of care, you need to have that come together at a state level as well and a federal level. I think the number one success factor is leadership, and I'm talking about at the director level, policy coming from that level. Also training. Training is a very important aspect of integration of services, and it has to do with clinical assessment, developing the tools that we both use, training on co-occurring disorders, motivational interviewing, consumer employer training. Motivational interviewing is something that we've all been trained on. We also had the benefit of working with consultants. The Zeologic group has taught us about the model of, it's called the CCISC model of care, which stands for Continuous Comprehensive Integrated System Care. And through that, built some infrastructure. So those have been, I think, some of the reasons we've been successful. San Francisco has a very good history of good treatment services. Some of the things that we've done in San Francisco is improve the training that we have provided to providers on both the mental health and substance abuse side. As I said earlier, learning this CCISC model of care, that's been a huge success. We're very lucky in the city and county of San Francisco to have an excellent training department, and so we have been training for about the last 5 years, but we're also looking at new models of billing. Here in San Francisco, the model has been any door is the right door, and that means that if a client shows up on the mental health side with a substance abuse problem that they're no longer turned away, they're welcomed into the program and worked with one-on-one to find out how it is we can best serve them. Also taking a look at integrated full-service organization models, that's been very helpful. And also have to mention our change agents. Change agents are a group of inspired and dedicated individuals who represent both the mental health and substance abuse side, and they work with their programs to teach them about co-occurring disorders and how to improve outcomes for our clients. And they've just been a wonderful group of people that have really taken the charge and led the way for better treatment for our clients in our service system. And I think it's really hard, for programs in counties that don't have additional funding to continue those projects, because it is a quality improvement process, and without funding, those projects can't continue to change infrastructure. I mean, I think this is the most important thing that we have done for our system as a whole. This has been a system-wide change to not close the door on people whose problems we don't understand. More money needs to go into funding, training people to have a core set of competencies, not to become the experts, but look at best practices and figure out, how to provide the best services for our clients.
The arms of my professional practice is a program called VIP Recovery Coaching. And in that setting, what I actually do is I go to an individual, I take treatment to an individual who otherwise would not go to treatment. So I would actually go to their house or their workplace or their living environment and set up a treatment program essentially in their environment. So I'll do an evaluation, I'll do a treatment plan, I'll do an environmental risk analysis, and we will set up a program in their environment, in their house. and monitor them with daily counseling and daily structure and accountability. That's kind of new. We're seeing now kind of cutting edge sober companions, which is a step down variation of what I'm talking about, where we will have someone living in the house of the person who has left the program. We are seeing now internet-based treatment, where people are actually doing their full course of treatment in virtual groups, group therapy, and one-on-one sessions, doing a iChat or a Skype or a video conferencing session with not only their counselor but with other group members. So you have group members that can essentially meet from different places geographically all over the world at prearranged times and do a group therapy session. So the client and the counselor rarely meet at all. I worked on a project where we would last year, where we rented a villa in Spain, in southern Spain, in Marbella, and we took 15 clients and we did a 21-day course of treatment. And it was 7 days a week, and all the clients started at the same time, and we ran them through a 21-day course of treatment and then monitored them via internet and monthly pre-scheduled phone calls for the next 6 months, and had really good outcomes. I think another cutting edge thing is the way that people are adapting typical addiction practices for process addictions. I've been doing some work in Holland where they have the first residential internet gaming program in the world. So there's a guy in Amsterdam who recognized, was getting a lot of calls from kids who were into internet gaming, playing World of Warcraft and other games where they would spend 12, 14 hours a day playing video games. They didn't go to school, they didn't work, and so having a program that deals specifically with those kinds of addictions that can be just as debilitating as drugs or alcohol. So I think those are some of the, cutting edge things. I think nicotine addiction, and we're recognizing as a field that nicotine is the #1 most deadly drug in the country. And we as an industry have been in denial about that. And so now they have certifications for nicotine cessation counselors. And we're seeing programs started to embrace that as part of their process.